Hi, this is Dr. Bhargava, and I have a few interesting cases to share with you today. Our first patient is a pediatric patient who underwent a technetium-99m mag3 renal scan for suspected hydronephrosis. So on the top we have dynamic blood flow images in the posterior projection, and at the bottom we have the nephrographic images 2 minutes per frame. So as we look at the flow images, 2 seconds per frame in the posterior projection, and on this last image we find that there is good flow to the left kidney and there is delayed blood flow and decreased uptake seen in the right kidney. As we follow the nephrographic images, we find that the right kidney does produce urine, but the urine is showing a cutoff at the level of the UPJ with proximal stasis. On the other side, the left side, we see prompt cortical transit, and then we find the radioactive urine in the urinary bladder, which is seen to become larger with time. So this patient has a suspected right-sided UPJ obstruction, where on the initial images we find delayed flow, decreased flow, production of radioactive urine, and some stasis proximal to the level of the UPJ. And so the next step here would be to administer Lasix and look at how this stasis responds to Lasix. So these are post Lasix images, and you can see that there is very minimal emptying seen from the right side. And here the technologist would draw the region of interest, ROI, and do the analysis. And what we are looking for is half time of emptying. And here half time of emptying was more than 20 minutes, and we made the diagnosis of right-sided UPJ obstruction. This is a good article to read on this topic of pediatric diuretic renography using technetium-99m mag3. Our next case is an adult patient who presented with right upper quadrant abdominal pain, and we performed a HIDA scan or hepatobiliary scintigraphy. On these early images, we find that there is prompt uptake of the tracer in the liver. There is excretion of the tracer into the bile ducts, and we see the gallbladder start to appear in the right upper quadrant. As we follow these images to the end of 1 hour of imaging, we find that most of the background activity has been removed by the liver. Most of the activity in the liver has been excreted into the bile ducts, and the gallbladder is distended. But at the end of 60 minutes, we do not see any small bowel activity, and that finding is called delayed biliary to bowel transit, and that's one of the signs of chronic cholecystitis. Of course, with this distended gallbladder, we want to give this patient CCK and see how the gallbladder contracts and what's the gallbladder ejection fraction. These are post CCK images, and here we see that there is barely any emptying. The ejection fraction calculated by doing the ROI analysis was only 11%. Normal, we know, is about 35%. Anything less than 35% is considered abnormal, and so we diagnose gallbladder dysfunction or chronic cholecystitis in this patient, probably the cause of their right upper quadrant abdominal pain. This is a good article published by the Society of Nuclear Medicine, a practice guideline for hepatobiliary scintigraphy. They describe the different patterns that can be seen with pathologies of the gallbladder, such as acute cholecystitis and chronic cholecystitis. Also, findings that can be seen with hepatitis and CBD obstruction. Our next patient is an adult patient who presented with abdominal pain, and they were found to have this calcified mesenteric lymph node. Although there is no desmoplastic or fibrotic reaction around it, this raised the suspicion that this could be a neuroendocrine tumor metastasis. Also, we found a ill-defined enhancing focus at the terminal ileum, and so a gallium-68 DOTATATE PET CT was recommended to diagnose and stage a neuroendocrine tumor. And we know that neuroendocrine tumors are very common to arise from the terminal ileum, and they commonly present with a mesenteric lymph node which shows calcifications and desmoplastic reaction. So this is the whole body image on the left from gallium-68 DOTATATE PET CT, and we can see physiologic distribution of the tracer. You see uptake in the pituitary, symmetric uptake in the salivary glands, there is uptake in the liver and spleen. Remember, spleen is more intense than the liver. On this study, there is excretion from the kidneys into the urinary bladder, and then we see these foci of abnormal uptake. Now, these foci are localized on the cross-sectional images. Here on the top right, we see the non-contrast enhanced CT at the site of the ill-defined enhancement seen in the terminal ileum. That shows focal intense uptake. This is the primary neuroendocrine tumor. The site of mesenteric calcified lymph node also shows focal uptake. This is consistent with mesenteric nodal metastasis. And then on the next slide, I have other localizing findings. One of them is a focus in the bone, and it may or may not have any anatomic correlate on the CT in the bone windows, but when there is focal uptake like this, this is consistent with bone metastasis. Remember, there is physiologic uptake in the adrenals, so this is the left adrenal showing physiologic uptake, and in the pancreas there are two additional previously unknown foci of increased uptake. So these are additional neuroendocrine tumors and additional primaries visualized in the pancreas. And I think since this radiopharmaceutical and the scan gallium-68 dotatate PET-CT is so sensitive and specific that as we gather more experience with this technology, we will find more number of cancers being detected, and the question would be as to how to clinically deal with these tumors. And most of these neuroendocrine tumors are differentiated tumors. They're slow growing, so maybe wait and watch would be a good policy for these tumors, but we definitely will see additional tumors in these patients. Here is a good review article on neuroendocrine tumor diagnosis and management using gallium-68 dotatate PET-CT. Thanks for watching.